Well, thank you very much for the kind introduction. I would like to express my sincere gratitude for inviting me here today. It's truly an honor. I know South Korea is known for its dedication to innovation and healthcare, and you have much progress in this country. I envy you actually a lot. So just being here today it's a huge honor. So thank you for inviting me. I'm looking forward to share my expertise with you. Today, I'm going to dig a little bit more into the practicalities. We heard Nick tell you about the story of shared decision making and what it is, and Fritz about all the general aspects about implementations. So I'm going to dig into a little bit more about details about how to implement shared decision making. So as I reflect on the journey we made in Denmark, I see many parallels between our two nations. Although both of our countries, Denmark is a small country. We have 6 million people living in Denmark. So we are less than 1/10 of the size that you are here. I think, but the size of Denmark is 2.5 times smaller than Korea. So we are in geographical size, still small countries maybe in the world, but I hope that we can lead implementation of shared decision making together. So I see many parallels here. And I hope that if we encourage patients and clinicians to participate in shared decision making, we can maybe foster a healthcare system that is more responsive, personalized, and effective. So I share this example with you today, hoping that we can spark conversations on how we can learn from each other, regardless of the geographical size of our nations. So this is the Danish healthcare system. This is Denmark on the map. And Denmark has 5 healthcare regions, and they are financed by taxes. So all healthcare in Denmark is completely free. We don't have any insurance. So it's free. For universities are free, hospitals are free, a lot of stuff are free, but we pay a lot of taxes. So every time I get my paycheck every month, they have deducted more than 50% of everything I owe, but then hospitals are free. So this is the trade-off that we have here in Denmark. So it's divided into 5 regions, and we are placed here in the region of southern Denmark. And as Fritz told you, here's the German border down here. So Hamburg and Kiel is just down here, Fritz, I think. So this is Germany down here, and I work here in the region of southern Denmark. And this region decided to implement shared decision making in 2019. I'll show you a little bit more about the timeline of this. So if you go here on the right side, this is the region of southern Denmark enlarged here. And we have all these hospitals in the region of southern Denmark. There are 5 major ones. So I'm based here at Lillebaelt University Hospital. So we have a hospital in Vejle, and we have a hospital in Kolding, and we have a hospital in Middelfart. So we have 3 hospitals. And then there are other hospital units that also have several hubs. And we are implementing shared decision making across all those hospitals in the region of southern Denmark. And that little heart here is psychiatry. So psychiatry in the region of southern Denmark is spread into 20 different sites. So we're also trying to implement shared decision making across 20 different psychiatry units spread in the region of southern Denmark. So this is the living lab that we are implementing shared decision making within. I hope that makes sense, so you can get a little grasp of what we're doing. So what are we doing in the Center for Shared Decision Making? We operate as both a knowledge and research center. So I'll show you in a little while that we have several units. So we do teaching. We educate local teachers in shared decision making and help them develop the skills of healthcare professionals. We do knowledge sharing. We facilitate initiatives across all the hospitals, but both nationally and internationally. So it's also arrange conferences, do webinars, do newsletters locally in the entire country. We assist local employees. So my center assists all the other hospitals in implementing shared decision making. And then the 4th thing is do concept development. We contribute to creating new patient decision aids and other tools to support shared decision making in clinical practice. So this is my business. This is what we do at the Regional Center for Shared Decision Making. these are the people. This is not an effort by me. This is actually an effort by all the skills employees at the Center for Shared Decision Making. And so we have a research and project unit. So we still do a lot of research in shared decision making. So all these people here are researchers. They work with either research or quality improvement projects. And are headed by another Karina. So we actually 2 Karinas in the center. And Karina is a nurse, a really, really skilled nurse who has done a lot of shared decision making, worked in the center for 8 years. And then we have an implementation unit. I think this is so fortunately, because now I can implement what I research, and I can research what I implement. So these 2 things go hand in hand. But all these people here, they implement shared decision making. So don't think of them as little mice who go out to the hospital and help. So this one here, Louise, she helps in the Department of Genetics, and she helps in the Department of Orthopedic Surgery, and she helps in the Department of Internal Medicine. Mia, she helps in surgery department, in gynecology department. So all these consultants, they have departments, each of them, that they help implement shared decision making. And it's led by Mette, who is the leader of the implementation unit. So this is how we implement shared decision making. And who are the green people here? The green people are those who work at the other hospitals. I just told you I was at Vejle Lillebaelt Hospital. But Lisa here, she's responsible for all the psychiatry units. And Stina is in one of the other university hospitals. She's their local implementation agent. And Annette is on the hospital closer to England, on the west coast of Denmark. And Mette is down here at the German border side. So all these ones, so I have local employed implementation consultants who are the implementation consultants of the other hospitals in the region of southern Denmark. So you have local buy-in. So well, let's get started on the shared decision-making journey where it all began. So in 2011, Vejle Hospital was designated as a specialized cancer center by the region of southern Denmark. And it was called the project Vejle Hospital, the Cancer Patients Hospital. It was initiated to transform the hospital into a patient-centric cancer facility. The goal was to prioritize patients more than their diagnosis. So we began to traveling to Boston, probably like what you are doing now, trying to learn from others who has been pioneers before you. So we were, I think, 15 people traveling to Boston, so all the CEO of the hospital and the head of the internal medicine, the head of surgery, the head of oncology, to get inspired by other people. And that was the very first time I heard about shared decision making. In 2011, I never heard about shared decision making before we visited Massachusetts General Hospital. And they showed us our decision aid, and I was completely sold. And I was working as a medical oncologist at that time. It just makes so much sense to me. It struck me. And then we got home, time flies. And then we went home and we wrote together a program plan on how to transform the hospital into a patient-centric facility. And shared decision-making was mentioned on page 27. So it was, I think the second last papers or in the program plan. So it took some years, but then in 2014, the hospital said, well, now we need to do something about shared decision-making. So I was employed part-time to build a center for shared decision-making from scratch. There was just an empty piece of paper, nothing. And I was still working as a medical oncologist. So I went to visit some people. I went to visit Anik, and I went to Wales, and I went to Dartmouth, and I went to London, and I'd ask people, what have you done? What should I not do? And what should I do? So I got inspired from, world-class leaders on how to go home and build a center for shared decision-making in Denmark where there was nothing. And then we established a steering committee and an advisory board. We invited some international advisors. So Adrian Edwards that you show, he's on our advisory board, and Don Stacy is on our advisory board. So we get advice from international advisors on how to build a center for shared decision making. And then we started small research. So the first 5 years was only research. We didn't implement anything the first 5 years. It was research and getting funding to start a smaller research project. And then we started a collaboration with the School of Design. What is the School of Design doing on shared decision making? Well, I'm a boring medical doctor. If I was supposed to develop a patient decision aid, it would probably be an Excel spreadsheet. My graphic skills I'm very visually oriented, but working in collaboration with the design school helped us build beautiful patient decision aids in a completely different style than what we could have done ourselves. And then we started getting the first research results, and we saw a huge impact. And Denmark is a political-led system because of the taxes. So the politicians started to see, wait, what are they doing there? Why is Vejle Hospital the hospital in the country with the most happiest patients? Every year there's a competition in Denmark where we can vote for the best hospital. And the hospital where I was voted the best 10 years in a row. The other hospitals, they hate us because our patients are the happiest in the country. They're the most satisfied patients in the country. And the politicians saw the numbers going up and they said, what is it they're doing? Oh, maybe it's the shared decision making and the research. How can we scale this up so it doesn't only benefit, the few patients who participated in the small projects? How can it benefit all the patients in the region? So the politician decided in 2019, start implementing. Okay to do research, but we need to implement this at all the hospitals on the map that I just showed you. And they gave us funding for it, but there was not that many funding. I think they gave us €500,000, something like that, for all the hospitals. So it's nothing. But it was still a big help to start implement shared decision making. So then we started implementing, and also in the middle of Corona, the COVID-19, but it went, I think, okay. But of course, it was slowed down a little bit due to the COVID. And in 2021, just after a few years, the shared decision making demand has grown rapidly. So the other regions started looking, oh, what are they doing in the region of southern Denmark? We must have such a thing too. So they hired us to come help them in some of the other regions. And here in January 2024, all the healthcare directors of the 5 regions decided that we had become a national center. So now we are a national center for shared decision making, and we will celebrate our 10-year university next week with a big national conference. So this is just a short glimpse of the story from what you can achieve in 10 years. So as Fritz just told you, implementing shared decision making is a complex process. You cannot just train the clinicians. You need to look at multiple aspects for being able to implement shared decision making. And unfortunately, I've seen many one-sided focus on one of the aspects of implementing shared decision making, that you just build patient decision aids and then you tick a box and I think, okay, I have 5 patient decision aids, now I have implemented shared decision making. That's not going to happen. You need to focus on multiple aspects to really implement shared decision making. And of course, there's barriers, I think, time, and we do it already, and issue like limited knowledge, lack of skills, lack of leadership, and system integration, they really obstruct implementation. So we recognized a need for a systematic implementation model, leading to the development of this model, which we call SDM Hosp. And it has like 4 main themes, and I will show you them in detail in the next couple of slides. So we have training of leaders. There was a workshop yesterday, and I said, well, the leaders, they are the one who's going to sustain this and help this. So we start with training the leaders. Before we even approach the clinicians or building patient decision aids, we start training the leaders because they need to understand what this entails. And then we start training teachers and clinicians, and we build patient decision aid, and we have a process plan. So let me show you to this in a little bit more detail. So I can go back. So let's look at the pie chart about training of leaders. Let's take a closer element. What does it mean to train leaders. And there are 3 layers here. The inner core here is shared elements. And in the beginning, we called them mandatory elements. Bad idea to call something mandatory for clinicians. They were like, nobody's going to tell me what to do. So we renamed it and called them shared elements instead of mandatory or obligatory. And then we have recommendations, something that we think is a really good idea if you really want to implement shared decision making. And then we have local adaptation. Because if you go out to, 60 different departments, they not all want the same. They want some kind of flexibility. And I remember when I visited Canada, they gave me 3 advices. And that was to adopt, and make flexibility. So you really, probably one size fits all is not a good idea. You really need to give them some kind of say themselves how it fits their apartment. So what are the mandatory or shared elements for training of leaders? Well, the leaders are sent to a class of a minimum 3 hours. And it's physical attendance. We could do it online, but the leaders also talk to each other how they can implement shared decision making in their apartment. So it's the 3-hour course for leaders in shared decision making. What it is, what's the model, what's the theory, what's the cost, but also what does it take to implement? When you go home, what are the resources? What should you do? And the teachers who teach the leaders are the local implementation consultants. The one either in green or in blue I showed you on the right side. These are the teachers of the leaders. And there's an obligatory course material. I don't want 50 different kinds of PowerPoints flying around. I need to know what's the quality in the material. So there are some obligatory course materials so I know what are we presenting to the leaders. And this is reviewed every year for updates. Recommendations could be like leaders at all levels. So who are the leaders? It's only the boss of the department. So it's the top boss. But it's also the leaders in the next couple of layers. It could be the leaders of the outpatient clinic. It could be the nurse leader, the doctor leader. It could be the leaders of the inpatient clinic. It could be the leaders of the radiation therapy clinic or whatever. So it's leaders from different layers. And we put them on the same class. And we mix nurses and doctors. And we want as many leaders as possible from the same department to participate over time. And then local adaptation could be we supplement the PowerPoint with something else. And if there's a large class, I have a teacher employed who teaches only shared decision making. And she can go teach close to the German border or in Odense or in psychiatry. So last class, she helps the local implementation consultant help teach the leaders. So this is what we do for training of leaders. Let's go to the next one. How do we train? How do we make sure that, every doctor, every nurse will know what it takes to get the skills to practice shared decision making? We use a concept called train the trainers. There are, in the region of southern Denmark, there are 30,000 healthcare employees. I have one teacher. She cannot train 30,000 healthcare employees, but she can train the trainers. So my teacher trained the trainers. So for example, close to the German border, there is a department of hematology. They want to implement shared decision making. Then they need to train some trainers. Maybe let's say they have 200 people employed in that department, nurses, doctors, secretaries. And we say, well, you are 200 people in your department, you need 5 teachers. 2 doctors, 3 nurses, or maybe a secretary. They should become the teachers of shared decision making. So my teacher teaches them shared decision making, and she also teaches them how to teach her peers. And that's shared elements is 2 days, so 2 full days, not in a row. They're at least 2 weeks behind the first teaching lesson and the second one, because they need to go back and try out the skills and come back and say, how did it go? So teaching the teacher is a 2-day course facilitated by the teachers from the Center for Shared Decision Making. And then when they have been trained, those teachers, those 5 teachers from the hematology department, then a couple of months later, they need to go home, start training the 200 nurses and doctors in the hematology department. So it's like what I call a pyramid game. I have this one teacher, he teaches those 5 teachers, they teach those 200 clinicians at the local department. So this is how we train the trainers and train the clinicians. This course also have obligatory course materials for both courses, both the trainer courses and the clinician courses. So I know what's in it, what's the quality, what is that we present them for, what's the newest evidence. And then there are recommendations. We need teachers from several professions. So we don't only teach or train the doctors. We would train nurses. And now we're thinking about training secretaries. Like secretaries, how are secretaries? Are they doing shared decision making? But your patients, they call into the clinic and they want to, move their appointment. Maybe they talk to this patient who moved his appointment 5 times. And it's about he lives far away from the hospital and then the secretary hasn't picked that up. So maybe she start, what are your options? You can come in the morning and in the afternoon or maybe on that. Oh, it's because you have the preference for this. So secretaries also need some kind, maybe on a small scale, shared decision-making elements, maybe even the porter. So now we are thinking about how we also train staff members who doesn't have direct contact with patients. So at least 2 teachers are trained in small teams, and at least 4 teachers in large departments or sections. So we're not going to go with 1 teacher. It's also about sustainability. People, they quit their job and move to another apartment. So we need to have several teachers in each department. And the teachers should also have influence on the local implementation. And then there are local adaptations of elements. I'll not go deeper into this because then I'll not get through all my slides. What is this word, decision helper? This is what we call our patient decision aids. Patients in Denmark did not understand what was a patient decision aid. They thought it was something about shared finances or, finding the hospital, I don't know. So we made a competition of what should we call a patient decision aid. So we had 200 people voting for a word. And that's why we named our patient decision aids decision helpers. It's supposed to help patients make a decision. So that's the word. So the shared element is that at least 1 decision helper should be developed in every department, and patient involvement is obligatory when developing the patient decision helper. So patients co-develop patient decision aids together with clinicians. They sit around the same table and co-develop it. So, and recommendations is how do you develop a patient decision aid? I'll get into more details on that. For example, we recommend organizing workshops when developing patient decision aids. And there's local focus on the quality of decision helpers, and it's according to the IPDAS criteria. And then we have local adaptation elements. Let's look at this. What is this decision helper? What a thing is that? So, when we started, there were very few patient decision aids in Danish, almost nothing. And just taking one, from an international website and translating it into Denmark was not always a viable solution, as either the tool for the certain decision, it did not exist, or the process of obtaining and translating and testing them was too expensive and time consuming. So we decided that we would have a template for building patient decision aids. So imagine that you were me. You were standing here and you are supposed to put together a PowerPoint presentation. So what do? You find a PowerPoint template and you put in your words in the template. That's what we do when we build patient decision aid. We find an empty patient decision aid template and we put in the clinical decision in the template. So this is how we build our patient decision aid. And when we began, we asked the patient, what kind of patient decision aid do you want? And our patient said, well, we don't want to sit with you in a consultation and look into a computer screen. We want something that we can touch and see and on the table. So to begin with, we decided that we wanted to develop an in-consult, a paper-based in-consult patient decision aid that you could see the full extent of while you were sitting together with the clinicians. And how did it look? So just want to show these are 4 different patient decision aids, 4 different clinical decisions built on the decision helper template. So they look like this. and I'll go into more detail. How do I end up with one of these in my hand, from getting an idea that I want some in hemodialysis, and I want one in diabetes, I want one in breastfeeding, or delivery, birth delivery, or whatever. The choices or the options are many. So how do I end up with one of these in my hands? What is the process? Well, usually, let's see, we go to the department in the hematology department and close to the German border, and they are starting the implementation process. And we tell them, well, it's mandatory to develop at least one. Find a decision in your department where one of these makes sense. It could be treatment of leukemia or some kind of where there's multiple options. And remember, the options always also to say, I don't want treatment right now. So usually there's always two options: this treatment or do not treat. And then I have an expert in these ones. I send my expert to that hospital, and she starts a kick-off meeting with a local decision helper team in that clinical department. And she has a recipe. She helps them. She's not developing this for them. They're doing it themselves. The clinicians and nurses and whoever on the team is doing this themselves. She's not doing the work for them, but she's holding their hands, leading them through the process. Then we have the workshop with the patients and clinicians, because the doctors will say, we think these are the pros and cons. And with you, Fritz, who say, now you and Nico says they maybe don't pay attention to psycho-oncology or side effects or quality of life. The patients say, well, I think it's good that you can see you live 2 weeks longer with that treatment, but what will it affect me? What about my financial toxicity, and what about, can I see my grandchild? So the patients get influence of the pros and cons in this patient decision aid together with the clinicians during the workshop. And then we go to find the template. We enter what came out of the workshop in the template. Oh, sorry. And then we have this first version. We go user test it. So we have some templates where we assess acceptability and usability, and we use the preparation for decision-making scale. So maybe we go try it on 15 patients on that open-end survey, and then we get some feedback. And then we, like you said, Enik, we go iterations. So maybe this one is, I think this is version 1, but sometimes it ends up in version 14. This is version 3. So maybe it's good enough in version 4 or 2 or 3. Sometimes it's not finished before you reach version 10. Depends. And then you get the final product that's ready, you can use it and implement it in the clinic. So this is how you develop a patient decision aid. So over time, you also realize that sometimes it's good to be able to send it out before the consultation. So now we also have this in an app-based version. The development process is exactly the same. I only need to enter the data into the template, and I can produce this or the digital version. It's not two parallel processes, just one same process. So now I think we have 68 different one, and then we have 32 more in development. So a total to get 100 different kinds of these ones. And there's most of this is in Danish, but I think Google Translate or ChatGPT can do a lot. So if you go to this website, you can see this one is all kinds of different patient decision aid. This is pregnancy and cardiac diseases and contact form, jaw surgery, malignant melanoma, kidney diseases, psychotic diseases, prostate cancer, lots of ovarian cancer, herniated disc. And when you press one, it will open up and you can see the PDF file of this one. You can see who developed it, what are the options, when is it going to be updated, who's responsible for it, and how many of the IPDAS criteria does it fulfill. So you can also see a quality assessment on them by clicking on the specific patient decision aid on the website. So I'll go through a little bit research data. So how is this, where did it come from? So I want to show you this study. It was published by one of my PhD students this year. And it was a trial on this one. She wanted to find out what effect does this one have. And This was on patients who had a really early stage of breast cancer, little bitty tumor in one breast, and the tumor was removed. And then the patient needed to decide whether they would have adjuvant radiotherapy to prevent the tumor coming back in the breast or not. So they had to decide. That's the wrong one. Well, I didn't take it. But there was two options: radiotherapy, pros and cons, and radiotherapy, no thank you, pros and cons. And then the primary endpoint was the patient-reported level of shared decision-making. It was by use of the SDMQ9 validated questionnaire. And then there were a range of secondary endpoints. Oncologist reported shared decision-making. We haven't seen much of that yet. It was using the SDMQ9 doc. It was other measures of patient-reported shared decision-making: fear of a cancer recurrence, decisional conflict, quality of life, knowledge, and decision regret. So a lot of secondary endpoints. So what did we do? We went to 4 big different hospitals, just not our own backyard. We went to 4 other hospitals, and we randomized 78 oncologists. So why did we randomize the doctors and not the patients? I think it's difficult for a doctor to practice shared decision-making using a patient decision aid in one consultation, then seeing the next patients not practicing shared decision-making. That would probably be a lot of bias. So we decided to randomize the oncologists and train half of them and not train the other half of them. And those 78 oncologists, they saw a total of almost 700 patients in this trial. So the control group, business as usual, didn't do anything. The intervention group, they got a very brief training in shared decision making and got to use the patient decision aid. So what were the results? Well, if you look at the SDMQ9 in the control group, it scored an average of 71, and it improved to 80 in the SDM group with a p-value of 0.01. And if you look at these are Collaborate and SDMP4. They're both 4 questions and 3 questions, really simple to use. And they are also patient-reported levels of shared decision-making. They also increased significantly. So all 3 measures of patient-reported level of shared decision-making increased in this large national randomized trial on using patient decision aids. So what about the doctors? Well, the doctors, they thought they were really good themselves. Look at that. They increased from 73 to 93. That they increased more than the patients actually said, but also with a p-value of 0.01. So sometimes when you talk about shared decision-making, you wonder, can it backfire? What if I engage my patients in decision-making? They must become more worried, more afraid, more anxious, more afraid of the cancer coming back. When they understand, when I show them the card from the decision helper and that it says if you don't take it, the risk of the cancer coming back will be larger. Maybe it could backfire. I could make the patients worried. That's why we measured the fear of cancer recurrence, and it didn't happen. There was no significant difference. The patient did not get more worried of the cancer coming back when we practiced shared decision making. So it didn't have that backfire effect. Also looking at decisional conflict. Decisional conflict scale is a tool that's designed to measure the uncertainty a patient feels regarding healthcare decisions. It's typically scored on a 5-point Likert scale, and then it can be converted to a range between 0 and 100. And where 100 is really, really decisional conflict, and low scale is you don't have that much with decisional conflict. So what happened to that one? We measured it both before the consultation and after the consultation. Before the consultation, there's not supposed to be any difference because they haven't even seen the doctor yet. They haven't seen the patient decision aid. So there were no difference before the consultations. But when they left the room, the patients who met a doctor who had been trained in shared decision making and who used the patient decision aid, the patient had less decisional conflict, significantly less decisional conflict. So one of our early studies was not a randomized trial. You don't need to do randomized trial You can do other kind of trials as well. So this was a pre-post trial. And in this trial, we looked at the 82 control consultations in a lung clinic. So this was on a diagnostic study. This was not about treatment. This was a patient who saw their general practitioner. Maybe they had blood, coughing blood, or they had a CT scan with a little something on one lung. The risk of lung cancer was probably very low, 2%. But they were still referred to diagnostic workup. And they have to decide whether they should have a bronchoscopy or a fine needle biopsy or go a PET CT scan or wait and see. A heavy decision sometimes. So we build a patient decision aid for diagnostics in suspicion of lung cancer. And then we do a lot of measurements before. Then we trained the clinicians, use the patient decision aid, and then we did after interventions. And I'm showing you this because I want to show you two things. Time. What does it cost on time? And I'm little showing you how many minutes they used to talk to patients. These were patients that came in suspicion for lung cancer, first time visit at a hospital. So before business as usual, in average, the clinician used 22 minutes and 5 seconds talking to the patients. After we introduced the patient decision aid and trained the clinicians, they used 24 minutes and 16 seconds. There's a difference, 2 minutes and I can't remember how many seconds, but it was not significant. So they didn't use significantly more time to use the patient decision aid, but still much longer consultation, I guess, than you have here. But the most interesting is this one. The blue ones here are the minutes before we did anything. So there were some consultations that were 5 minutes. There were 3 of those. There were consultations that were 10 minutes. There were 12 of those. But there were also consultations that were more than an hour, 55 minutes, 50 minutes, 45 minutes. So the spread, the length of the consultation was this before we introduced shared decision making. Then we introduced shared decision making, and look what happens. The timing of the consultation got much more uniform. So I think it helps structure the conversation. The one with 5 minutes, they did disappear, but all the long ones, 55 minutes, 1 hour, they disappeared as well. So shared decision making does something of the structure of the conversation. So let's look at the final element, the process. And this is quite busy, so I'll just show you the plan of what it is. And when you show this to department leaders, they go, oh, this is a lot. And we discussed with them whether we should give them little pieces by time or we should give them the full picture. This is how an implementation process would look in a department. We actually print this out and give them to this. And this is in Danish. I translated the main elements. So you start in week 1. You have a pre-meeting. In week 2, you select your local team. In week 4 to 6, you do local pre-meetings. Then you have a planning meeting. Then you train the leaders. Then you train the teachers. Then you have meeting again. And down here, you start developing your patient decision aid. So this is a process implementation plan would look like in a clinical department, shared decision making. And this is all the departments at the hospital where I work. So we have like a Gantt chart with what are the pre-implementation phase and implementation phase and post-implementation phase. And where is it? Is it in Kolding or is it in Vejle hospital site? And how many employees are there at that local department? And then we have this. It's a dashboard. So it's the same department. We have a dashboard in the center. And we can see here cardiology and physiotherapy and lung medicine, orthopedic surgery. Are they green, yellow, red, and what are the causes and what are the actions, what kind of data, which implementation consultant is responsible for implementing in that department. And the CEO of the hospital, the very top leader, he comes to that dashboard every 2 or 3 months, goes through all the department with the implementation consultants. And at the first pre-meeting at the local department, he goes with them. He sits with the local implementation consultant talking to the leaders of the orthopedic surgery department, telling them why they should implement shared decision making and that he will track it on the dashboard. So this is about leadership. This is the last part of the implementation. So it's usually a year. And after this, you have sustainability. How do you keep sure that they don't think of it as a project that fades out after the implementation phase? And here's the decision helper and how to integrate the decision helper. So where are we now? So as I just told you previously, we have either developed or in the process of develop 100 different patient decision aid. We trained almost 4,000 leaders, teachers, and clinicians in shared decision making, and 62 different departments or clinical areas in the region of southern Denmark is in implementation. And we also helped other regions implement shared decision making. So I can rent out some of my employees to help the other regions. So I think this was the practical elements of implementation. Thank you.